So now I would like to invite Dr. Sadaf to give the next talk on what to do once we suspect that the patient might have a bile leak. Dr. Sadaf.
So once again, a very good evening to all. And I don't know, my slides are being seen?
Yes, yes. Go to the first slide, please. Yeah.
Yeah.
Yes.
So I would like to thank the organizers to make me a part of the team of today's theme of bile duct injury. And I have been asked to talk about post-cholecystectomy bile leak injuries, how to investigate exactly. And I would like to convey that investigating a bile duct injury is a part of managing bile duct injury. So there's likely to be some overlap, and we have otherwise not touched it in post of bile duct leaks in the other discussions. And to me, the investigation and management is a multidisciplinary approach, as it is for all of us, because a post-op leak may be a fistula representing minor leak as a cause of cystic duct blowout to a major leak, which would be from a complex injury, a rapidly stricturing hilar disconnections with vascular injury. So it can never be a story from one OT where it happened to where it was repaired. It involves many more people, your radiologist, your medical gastroenterologist, your surgeon specialist, the whole lot chunk of the laparoscopic general surgeons who refer you the patient should also be aware of how to manage it in initial phases and should participate subsequently. So multiple factors actually dictate the subsequent investigations to be done. First is where did the injury happen, because this gives you a gross idea what were the levels of the hospital where the cholecystectomy was done. Is the operating surgeon actually suspecting a problem? When did she refer the patient? Time since the injury? What is the clinical condition of the patient at arrival? Is there a drain in place or no drain? Is there any obvious bile leak in the drain? What is the quantum of bile leak? And what information did you gather from the surgeon and the procedure recording if you have one? So it is a clinical presentation of the patient which dictates the investigations to be done, as well as how the investigation should be sequenced. The patient may be unstable with symptomatic fever, tender abdomen, raised counts, hypotension, no drain, drain removed, not draining in case of uncontrolled fistula, and the patient is likely to be stable or leak coming out with not much signs and symptoms if there was a drain. If there was no drain, then you have to have a high index of suspicion, and it has been already discussed. And in uncontrolled fistula, the patient may be sick to stable as well. Now, what would be the initial investigation? All patients are to be subject to a liver function test, a kidney function test, and a CBC, basically. A liver function test is going to give a lot of information about the patient, whether there is already incoming EHBO after the injury, whether there is significant transaminitis to anticipate a vascular injury, a major vascular injury, or whether there is mild transaminitis due to some amount of leak absorption, the kind of hyperbilirubinemia, the presence of comorbidity. In AKI, your kidney functions may be deteriorating, your counts may be high, you may have thrombocytopenia when there is already sepsis. So much of information comes from your baseline investigation. The second investigation would be an ultrasound abdomen for all patients, which in light of clinical presentation can guide you further. It gives you information regarding the collections. It gives you information where there's already some amount of dilatations occurring and presence of free fluid. But this investigation is operator dependent. Some form of advanced imaging is actually an integral part of managing bile duct injury. The role of imaging in these patients is, first of all, to establish a diagnosis of bile duct injury. Not always when you suspect, it turns out to be bile duct injury. To look into abdominal collections, to delineate the type and extent of injury, and to plan appropriate intervention in these patients. So What you do is you need to take a call between CT scan versus MRCP versus ERCP based on the clinical scenario. In patients with persistent symptoms, nausea, vomiting, fever, distension, you will go for a CT scan first, following ultrasound. We look for the collections and the abscesses if present. You need to take a lead from concurrent doing of CRP, procalcitonin, lactate in selected patients, and pick up the need of urgent intervention for sepsis control. When there are features of peritonitis with CT showing a diffuse leak or fluid in the abdomen with no localized collection, sometimes in these patients, you need to take them for an immediate damage control surgery. On the other hand, a patient who has collections is comparatively stable might only need a radiological guided aspiration or pigtail. So we are not doing the part of EHPO, but some patients may have early setting of EHPO with rapidly stricturing ducts, and sometimes the patient may be referred late, and there may be disconnection between the presentation and the present situation, and you might have to rule out malignancy in some patients. So MRCP would be other important investigation, and ERCP. By many in present era, CT is recommended as first investigation. The World Society of Emergency Surgery consensus guidelines published in recent past actually suggest that all patients should undergo CT scan. After stabilization, MRCP, CMRCP should be complementing all patients to classify the kind of injury and tailoring the treatment. And the need of ERCP and PTC should be dictated as per the grade and level of injury, as well as existence of concurrent cholangitis. So the role of CT scan is to look into the collections, the perihepatic fluid, the ascites. It has a very important role in identifying any associated vascular injury. It picks up biliary obstruction with upstream dilatation in cases of long-standing injuries and neglected patients. It can show you the lobar hepatic atrophy in vasculobiliary injury, and a concurrent sign of features of secondary biliary cirrhosis can also be picked up on CT with widening of fissures and nodularities. About vascular injury, if you don't see from the perspectives of surgeon, if you see from radiological investigatory studies, the incidence is as high as 47%. The commonly injured vessel is the right hepatic artery. Luckily, unusually, this does not lead to significant early complication, but it is likely to pose problems during reconstruction because the injury is likely to be very high once there's an associated vascular injury, and the transverse artery might get injured once you approach that area, and the repair must be difficult. And another important aspect of knowing about vascular injury once you receive the patient is that you will take the anastomosis more seriously, because these patients are likely to have an anastomotic stricture due to ischemia. Their follow-up would also be more vigilant. So these are some images, because the audiences, if they join and see later on the YouTube, how would they pick up the collections and how helpful the CT scan would be. And you can see such situation where somebody has injured both the artery and the vein, and ischemic liver seen, vasculogram showing there is cutoff of the right-sided blood supply. But there are shortcomings with CT scan. It does not reliably distinguish leaks from the postoperative collection. The patient may have some other kind of collections like blood, pus, serous fluid, and it's not always a bile leak. It cannot distinguish precisely the site of location and the active state of bile leak. The active state might not be important as per managing, but then due to overlapping areas of collection, it is not a good investigation to classify the injury according to the site of the injury. MRCP as such next is a gold standard investigation. It gives you a complete morphological evaluation of the biliary tree. It offers you a detailed information about the integrity of the tract, where exactly how much it is disconnected. Its yield can be enhanced by doing a CMRCP by using contrast agents. It can be more informative than the conventional MRCP. It actually allows you to detect active bile leak or extravasation into the fluid collections in delayed T1 post-contrast images. It gives you the site of image, type of leakage and type of injury with accuracy, and it shows you whether the fluid collection is a bilioma or not based on the signal void intensity, like that of bile presenting as low signals in T1 weighted images. There are many radiologically oriented papers who describe it to be CMRCP to be very highly specific, as high as 100%. For example, a conventional MRCP over here would let you know and think while evaluating this patient that if this is not taken into consideration, a good anastomosis and hepaticogynostomy would suffice. But a CMRI would tell us that there is a lot of area to be left undrained, and this patient requires two anastomosis. Now, to finish in time, I would skip some part of my presentation. It is a word about hepatobiliary scintigraphy. HBS would actually confirm the bile. It's a very good investigation. And then it will show us a definite relationship between the leak and any fluid collection over there. Because if it is bile, then you come to know with the HIDA scan, it actually delineates a primary route of bile flow. It provides you functional information once there's an active leak going on. But the thing is, practically very few centers are using it because of the cumbersomeness involvement, where you get MRCP done in minutes. You have to do it over hours. And then this is hepatobiliary scintigraphy, which shows that there's a leak, and with subsequent time the leak is active, and it goes and shows you that the whole lot of collection this area is a bilioma. The shortcoming is that it does not have any spatial resolution. There's no clue about the extrabiliary structures. It has poor sensitivity in patients who have hepatic dysfunction, and once there are large defects, it does not show you the exact site of leak, because it might show you a stump of some sites in the proximal disconnections, but then you don't have exact idea what type of E the injury is, E3, E4, E5. So now what is the need of ERCP and PTC while investigating these patients? They are both invasive investigations. We all agree about it, and usually should be indicated if it is required for 2-in-1 or therapeutic and diagnostic indications. ERCP might be required in minor injuries when you understand based on your clinical observation of the patients, and if you have proved that these are cystic, this is a cystic duct blowout, the laceration is less than 5 mm, there's a partial clipping. Some good competent endoscopists can bridge a type C right ductal injury, sectoral ductal injury, and all they have to do is they do sphincterotomy and stent placement. A detail of it would be coming up in the next presentation. The PTC may be indicated in some complex injuries where the injury has been neglected for some time. When there is sepsis, cholangitis, and conjugal abscesses, it is preferable to drain both the symptoms if you want to optimize the patient for surgical repair. Coming to the differences of ERCP and MRCP, the ERCP will let you know, if you think about diagnostics with ERCP, then you understand that the bile duct injury is high. But MRCP would show you what is happening into the inner ducts. So how to sequence is, once the patient is optimal for repair after CT, drainage of all collection, controlling infection, inflammation, we have to, if we are a proponent of anything early, delayed, late repair, all surgeons would need an exact roadmap, and the proposed, and this can come in the form of the cholangiogram. You have to put up the patient into a classification to plan your treatment while investigating the patient, and sticking to one of the classification to me is actually important. And the ideal classification in acute setting once a patient has come after injury would be a Strasberg classification, which is an extension of Bismuth classification. There's a vast variety of classification, and if you want to discuss them while investigating, you need another 20 minutes. So the Strasberg is an easy classification to remember, wherein you have the type A injury, cystic duct stump has given way, or there is a duct of Lischka leaking. These type B injuries are the right sectoral duct or the right posterior duct, which is ligated, and many of these patients might be going unnoticed. Type C is once there is leaky right posterior duct, and type D are those which are lacerations. This might be small hole when energy source injuries are there, to bigger laceration, but the continuity is maintained. And E1 to E5 are those like that of the bismuth, where E1 is more than 2 centimeters stump, E2 is less. At hilum, it is E3. Beyond hilum, the disconnections are, the disconnected hilum is E4, and a more complex injury is E5. And there are many more modifications. I'll not go into it, but Stewart's Bay classification takes into consideration about the mechanism of the injury. He also puts up a class 1 injury where you have recognized it on the table with a cholangiogram and not much harm is done. The class 2, the continuity is there, and it's almost similar with addition of vascular injury, class 4. Now, this is an important classification which has been put forward by the European Association of the Endoscopic Surgeons, and this is more simple. This might gain popularity and is recommended by World Society of Emergency Surgery to be used in future. They have also the publishers or the people who have worked on this classification has in their discussion made a mention about Professor Kapoor's editorial in a paper in a journal, where he has actually proposed a similar kind in his discussion classification, where the abbreviations are little different once they published this paper. So it takes into the account the anatomy, the time of referral, and the mechanism with very simple things like the occlusion is complete or partial, the main pancreatic duct injuries, there are no non-main pancreatic duct is divided, and then the vasculobiliary with abbreviations of which vessel, and the timing of the injury, whether it's an intra-op or the early post-op or the late post-op. And there are many subset of patients who do come late post-op and there's already a stricture set in, and the mechanism of injury. So to put it up in one slide, on receiving the patient, we have to do an ultrasound LFT baseline investigation, other relevant blood investigation like CRP, PCT, blood and bile culture of aspirate. In unstable patients, subsequently, you should go first for a CT scan, a CT angio, if your radiologist is available. And it's good that you do it in presence and you don't give two contrasts to single patient and read it retrospectively. You should do then dependingly in this patient, there would be a call taken for damage control or the need of ERCP, PTC or percutaneous drainage. In stable patients or the patients after stabilizing or before anticipating or contemplating a surgery, you have to do an MRCP, a CMRCP or HPS, and take a call for subsequent management in minor injuries, a therapeutic. Minor and major means you should be knowing exactly the type of injury where a therapeutic ERCP can be done. In more complex injury, a more delayed approach is probably agreed upon by most of us. And in cases of patient stable non-complex injury, an early repair which is proposed by many of it can come in. To discuss a few case scenario, a simple injury blown out in this patient who is 45-year-old lady who presented to a surgeon for only biliary colics. She underwent colic lap chole. Drain output was 400 cc on first post-op. She stayed in hospital up to 15 post-op without any investigation. The drain coming down to 50 ml. He removed the drain and discharged the patient only to readmit on third day with features of peritonitis and collection. And then on dates are important. On 17th March, the patient is operated. On 12th April, she undergoes laparoscopic lavage. And then on 4th May, the drain is still persistent. The patient is referred to SCIMS, to our department in particular. And the patient had 40 cc collection on ultrasound, which was aspirated despite of the drain. We did an MRCP to find out that there was nothing but a little muck reported in the distal part of the CBD, and ERCP clearance was done with sphincterotomy. And this patient took 2 months otherwise and settled with us in another 5 days. So another scenario is a total transaction where 24-year-old lady in a remote village in a private hospital underwent cholecystectomy on 10th of December. And she came to us and saying that despite of recurrent visit to the concerned doctor, she was not that sick, but she had pain, abdomen and fever on and off. After a period of 3 weeks, we saw that ultrasound was showing a large collection. We admitted the patient and did a CCT first, pigtail drainage of the collection, made the collections into controlled fistula and discharged her to plan a surgery, after MRCP dated. On MRCP again, we saw that there was a small collection. We still decided to wait. And then subsequently, a patient had a definitive surgery on 15th March. This is how the MRCP of this patient looked like. The hilum was intact. There was a suspicion of a small fistula connecting to the duodenum, which was actually there, which was taken down, and a big hepaticojejunostomy was performed on this patient. Another scenario is that a patient who presented with the peritonitis to us. He was a 32-year-old male post-cholecystectomy, not post-cholecystectomy. During laparoscopic cholecystectomy, they actually picked up the bile duct injury intraoperatively, whether they consulted somebody and under guidance, they did a loop hepaticojejunostomy, which seems to be not an appropriate guidance for doing a loop hepaticojejunostomy. And first post-op day, the patient had a lot of bile coming through the drain, which was a big drain placed. The patient was referred on 4th post-op in a sick situation with features of peritonitis and hypotension. He was resuscitated. And what we did is we did not investigate much. We took the patient straight away for surgery. We took down the hepaticojejunostomy, repaired the jejunum. There was a lot of edema and inflammation. So we added a feeding jejunostomy, and we actually put in a tube into the system because the stump was good and the dissection was thought to be, we won't be harming much. And this patient then on subsequent cholangiogram, this was the picture. And once we thought that we have adequate length, after some time, after everything settled down, another 6 weeks, we called him back and did a repair. Now, this is another patient, a young female who presented to us with intraoperatively again diagnosed bile duct injury, lab converted open to do nothing. They left the drain. And this patient came to emergency, did not report to our department. On ultrasound, they picked up 80 cc collection. And then a CT confirmed same. A pigtail was placed. The drain was not draining, was removed. She was planned an MRCP and discharged. But subsequently, she was planned an MRCP, but in hospital, she developed COVID infection. Due to this COVID infection from emergency, she says she was discharged and was asked to report after 6 weeks. She was lost to follow-up, and she came to our department only after 6 months with jaundice, but luckily she did not have any cholangitis. We thought of doing a fibroscan in this patient, besides all investigations, and we saw that the already deteriorating score of 37 had set in. This patient had delayed the surgery for quite some time. After August, the injury occurred. In March, next day she underwent Roux-en-Y hepaticojejunostomy. We labeled it as type 4 injury, both based on her MRCP as well as the operative findings. This looked like a disconnected system. On table also, there was a septum in between. And we tried to put, once it is on beyond the hilum, then it is difficult to put the anastomosis together. And some of the patients who have a clipped injury go into rapidly progressing cholestasis, and they have PTC being done first. So these are the instances how the clinical presentation of the patient takes a lead. The stump is big, and this is a little older patient. Before the concept of doing and luring out the vascular injury in all patients, I still feel that we don't have to do much for the vascular injury, and this patient could have enough length to open up the duct proximal to the clip. And we have seen, I've gone through the literature also, there's a little second peak in occurrence of bile duct injuries. Initial days, we had worked a lot about bile duct injuries, and the incidence was high. There was a decline in bile duct injury cases in our hospital, and then in 2022 we had a surge. So we went back to look into what is going wrong in these patients, and why did we have an abrupt rise from 5 to 11 cases reported in 2022, and 23 again with our efforts it came down to 6 cases referred to us. The maximum injuries were from the particular district. Most of the patients presented within were referred, and they have good knowledge of referral of the patients. We also saw that the presentation, the patient had peritonitis in 13%, and there were multiple intra-abdominal collections. Bilioma per se were in 33%, and there was some amount of jaundice present at admission, at least in 64%, though the highest presenting symptom was jaundice, and a pain followed by pain abdomen. Cholangitis was seen in 20%, where there was already stricturing occurring, and we did not have any type B injury picked up. Maybe they were not referred, and because of no symptoms. And the maximum number of patients were type D, and the most were type D and type E1. Now coming to the management. Early management included exploration lavage in 21%, pigtail drainage in 47%. This developed over a time. Initially people were reluctant in draining the collections. Then ERCP and stenting was required in 28% of the injuries, and Roux-en-Y hepatico-jejunostomy was performed in 71%, of which 2 were done for right ductal injuries. The post-op complications were maximum were surgical site infection, and the bile leaks occurred in 5%.
I think you can
So one important thing I'll just highlight, that is the post-op follow-up, a long-term follow-up. We saw that edge stricture was seen in almost 19% of the patients. And to summarize, this is just a last slide. Post-operatively, in cases of suspected bile duct injuries, fistula leak, you should think and take it as a serious emergency. Early and appropriate investigations are key to proper management, as some patients may qualify early repair as well. It is important to sequence the imaging appropriately to address this emergency. CT scan is recommended to be performed early, and in most of the cases it should be done, especially in complex injuries. Proper planning with CT angio may be crucial. Mapping of biliary tract and exact location of the injury for classification grading. MRCP and CE-MRCP are gold standard. Delayed repair, a remapping with MRCP after maturation of the stricture may be necessary. ERCP is likely to be a single station approach for the injuries which qualify for ERCP treatment. PTC may be required in very small subset of patients with cholangitis. So perfectly classifying the injury with judicious use of investigation can give better outcome in hands of experienced hepatobiliary surgeons in this disaster. Debating about timing and all those things are of less importance, but I'd like to make a point that we need to weigh between delay for control of infection and investigation to a prolonged delay when there will be a stricture would be very bad and cirrhosis is already there. So time since injury, clinical presentation, findings on CT and MRCP is going to guide us to appropriate treatment and tailoring in each patient as required. Thank you very much.
Yeah, I think I'll make 2 quick points, since the emphasis is basically on investigations when you find bile in the post-operative, in the drain. Like what exactly you do and how do you proceed. Ultrasound, many of us would say it's ultrasound, but my personal feeling is ultrasound is very unreliable at this stage. And if you are shifting the patient to radiology suite, you might as well do a better imaging study on this patient, be it, again, whether MRCP or CT scan. Personally, I would go in favor of MRCP because that will tell me the biliary anatomy as well as also confirm if there is any collection and where the collections are located. Though it is said that this imaging may not be very good, particularly imaging of the biliary tree in presence of collection, but somehow you would be able to make out what exactly is the type of injury. It may not be very good, but yet you can make a fair impression on the type of injury. So my choice would be for MRCP, MRC and MRCP rather than CT scan at this stage. And ultrasound, obviously, I just roll it out. It's probably of no good in the post-operative period, in the post-operative abdomen. And having said that, a word about this biliary scintigraphy. This investigation may not be available in most of the places, but where it is available, certainly this is a very good, reliable investigation, particularly at this early stage of bile leak. Just to cite an example, day before yesterday, we did a difficult cholecystectomy. It was a gangrenous cholecystitis. The cystic duct was unhealthy. So yesterday in the morning round, I found there is a lot of this thing in collection in the drain bag. So I was not very sure. My resident said, sir, it looks like it's bile tinged. But I thought there's a lot of hemolyzed blood and that may be giving some kind of impression of, this bile tinging and all that. So under the circumstances, patient was absolutely stable, no tachycardia, abdomen was soft. So there was no really, pressing the panic button. Yet you need to decide whether there is a real bile leak or not, because your subsequent management would proceed accordingly. So at this stage, to settle whether if there is bile leak or not, biliary scintigraphy is a very reliable investigation. This would definitely confirm whether there is a bile leak or not, which MRCP may not do because MRCP is not a dynamic study, but scintigraphy is. So you can settle this question whether there is a bile leak or not. And if there is a bile leak, whether the bile duct continuity is maintained or not, because you can see the isotope in the duodenum, that would confirm that the bile leak is bile duct is intact. So, there is probably you would think there is probably a bile, minor bile leak. And if at all it is leaking, whether it is leaking out completely or it is going and collecting in the abdomen, in the pelvis, that also impression you would get on the scintigraphy. So where this facility is available, I would certainly fall back on this test, particularly to settle some of these, difficult questions in the early post-operative period. Thank you.
Thank you.
Anu?
Sir,
Yeah.
to add to what Dr. Abrar was saying about scintigraphy, especially in a patient who doesn't have a drain and you have a suspicion, because of its extreme sensitivity, it's a very good investigation. And if you remember, like earlier, we used to do a lot of these scans to determine whether there was continuity. But if there is a large fistula, many a times, even if continuity is there, all the dye goes to the bag, and so we stopped doing it because many a times it didn't really pick up, because if it's a large fistula, it goes preferentially to the bag. And about the MRCP, in the acute situation, if our aim is to control sepsis and drain all collections, I still go towards CT and MR in presence of large biliomas. Many times the information about the biliary tract and the kind of injury that we are trying to do, that we don't get. So I'm not a big fan of doing MRCP in the acute condition, a lot of collections there. Later on, of course, when you're doing the elective surgery, it is the roadmap which is required. After having drained collections, and if there is a thing that there might be some continuity, like, my residents will sometimes say, the patient is passing colic stools, there is still a fistula, do we need to do an ERCP to stent? Then at that stage, once all collections have been drained, I might do an MRCP just before ERCP to see that there is continuity.
So just a few points. One is LFT. Some people do a routine LFT on day 1 after lap chole. If it shows some derangement, again, it raises an alarm, but a normal LFT doesn't rule out a bile leak. Second, ultrasound. Obviously, ultrasound is the first investigation. But if it shows a collection, it is there. If it doesn't show a collection, it doesn't mean that there is no
No,
collection.
it's still there.
So if ultrasound doesn't show a collection, but you have a suspicion that there is something wrong, please don't stop at that. Go ahead and do a cross-sectional imaging. Now, between CT and MRI, points have already been mentioned. One advantage of CT scan is that if you give oral and rectal contrast also, which you should, you would not miss a duodenal or a colonic injury, which can manifest the same way as a bile leak. And I'm sure all of us have had instances where initial suspicion was a bile leak, but it turned out to be a duodenal or a colonic injury. The problem with MRI is that if there is a biloma, it will obscure. So MRI is good to detect a biloma, but to delineate the anatomy, the collection either has to be drained or you need to rotate the image in different directions on the screen and see. Because the advantage of MRI is that it tells you about biliary ductal continuity, which some endoscopists want before they go ahead. I think Avinav will cover this point when he makes his presentation. Want. The only situation where you should probably go for direct ERCP without an CT or MRCP is when you suspect that the problem is because of a retained or a slipped CBD stone. So that is the situation where pain is the predominant symptom. Patient has undue pain, but features of sepsis are not there. Features of infection are not there. And retrospectively, when you look at the ultrasound or the operative findings, you had multiple small stones in the gallbladder, a wide cystic duct, where there is a possibility that during your manipulation of the gallbladder, a stone may have slipped down, which one, it would cause pain. Second, it can cause a cystic duct blowout also. That is one situation where ERCP, an early ERCP would be very, very useful. Scintigraphy, over the years, I have found that, and I have now changed my opinion, that scintigraphy is a good investigation if you want to rule out a bile leak. So if your suspicion is low, the situation which Dr. Ibrar described, and I distinctly remember two cases where we knew that it is not bile leak, but the patient was not well. So we got a scintigraphy done, which showed that there is no extra biliary activity. And then we found that the patient was not well because of some other reasons. In one case, it was viral hepatitis. In another case, it was a precipitation of a leukemia, acute leukemic crisis, because of which the patient was not well. So scintigraphy is good because if you don't see any activity outside the biliary, there is no bile leak. It is something else which is happening inside. So these are a few points which I wanted to make. And again, those who are watching, students and practicing surgeons especially, and those who will watch these videos, we have covered extensively about bile duct injury in these 2 days, but still, if you want to read more about bile duct injury, please send me a mail, vkkapoor.india@gmail.com. Just write BDI in the subject of the mail.
Sir, I have a question, like to Dr. Sadaf and the other panelists. Would you say there is any role for a relaparoscopy if you're suspecting a bile leak?
Yeah, I actually went into looking for a relaparoscopy or diagnostic role of laparoscopy in bile injury. There isn't much thing covering up, but there is a possibility that if the surgeon has a strong idea that there is no bile duct injury committed, then in younger patients, it's not an option in all patients, like high risk patients, and it needs general anesthesia. So I should say that I don't have an appropriate answer for that, but I thought about a similar question and tried to look for role of diagnostic laparoscopy. And there are people who have written a case report or two picking up only laparoscopy and giving a peritoneal lavage. But as such, there isn't much mentioned in the consensus guidelines.
I would say that at a place where the other investigational facilities are not easily available, there are logistics or costs issues. In the early postoperative period, day 1 or day 2, if the patient is otherwise fit for an anesthesia, I would suggest that it should be kept as an option rather than doing nothing.
I would do relaparoscopy not to correct any injury or the bile leak or anything, but to drain out any untrained collections. Because when there are diffuse collections in the pelvis and the abdomen and all that, radiological drainage is not an answer. There you have to do a relaparoscopy and drain out all these quadrants. I mean, look at that and then drain out all those. And any attempt to control the cystic duct and all that is obviously is not the, I mean, approach here, or should not be attempted. Whole idea
Sadiq,
is
you
only
want to
to
say
drain the
something? We have
collections.
two,
Yes.
2 more minutes for this session. Sadiq.
So I need to defend Ibrar in this. See, I mean, we are talking about CT, MR. The bottom line is, if you're looking for collections with equal sensitivity, you will get on MR, the collections. And you may get additional information on bile duct. As you say, if you work on the workstation, you will be able to get information about the bile duct. So a single investigation would be MR, which will give also the location and the number of collections. The only problem is CT is much quicker. In a patient who is sick, they are able to undergo a CT scan more conveniently as opposed to an MR, which takes time, and it takes at least a half an hour before we do an MR. So, in that context, it may not be the most appropriate in a sick patient. The other thing about laparoscopy is, a lot of times we've grown up looking at doing percutaneous drainage and multiple drainages, but the radiological drainage is not always adequate. And if you need to do multi-quadrant drainage, then I think a laparoscopy and drainage of all collections and placement of good drains in the subhepatic space may be an option when you are dealing with bile leak and bile collection, bile peritonitis, and situations like that.
So would you take time into consideration, like time after injury, like because patients are referred at various time intervals, like about this re-laparoscopy?
So see, Anu, it is with in context of draining all collections. So irrespective of any time when the patient presents, say there are 2 or 3 collections, subdiaphragmatic, subhepatic, and then there is one in the pelvis, and you're going to put 2 or 3 drains. But by laparoscopy, you would be able to drain all of these and would target the subhepatic area to place your drains. So I think it's a underestimated kind of intervention, which is not much harmful, but at least it gives an opportunity to completely clean the peritoneal cavity and collection. And generally, when we have explored these patients, there is a lot of debris and all also present in this. And these we can evacuate by a good laparoscopy lavage as opposed to a pigtail drainage.
I think actually, I asked this because, supposing a surgeon has done a lab coli in a nursing home, and like if these are kind of guidelines, then, if they have to tell the patient, okay, I have to take you to the operating theater again, give another anesthesia and do. So these thoughts also come to my mind when we think of re-laparoscopy and like.
So we can't always think in terms of what somebody else would do, it's a question of you have X number of options. You have to judiciously use them depending on where it is, what you intend to achieve by that. And, over a period of time, at least I have realized that it's a very good intervention in early and in multiple collections. It is more reliable than placing multiple drains. But that doesn't mean that each time I would always do it. You would still decide in each individual patient that what kind of intervention is required. And one more point which I want to add in investigation, which we mentioned, but I want to emphasize again and again is getting adequate information from the place where the injury has happened is important. And of course, if recording. So we need to emphasize on people that, if there is a difficult situation they are encountering, difficult cholecystectomy, they should record that. And nowadays, I don't think it is difficult to have a recording of a procedure. So if they record it, it's good for them because the referral would be good, their patient would be benefited. And if you see a recording of cholecystectomy, your perception of the whole procedure would be different, and your approach may change based on what you see at that point of time. I think that's an important, I would put it as an investigation which you should look at in the immediate period when the patient is referred.
I think we need to move on.